this week on the BackTable podcast.
This is why it's important to see clinic. It's important to see clinic because you see these patients 2 years after you do this massive operation and you realize that they're going to do okay. And it makes it easier to handle the problems that come in and to talk to these patients because you know what they're going to look like in 2 years. I can't tell you how many times we've had patients come in with their entire extended family when I meet them because everybody thinks that mom or dad is going to die and this is the end of it. And then when they come in for their 1 year follow-up, they're by themselves. And you say, where is everybody? Well, they're out shopping or taking care of themselves. So I think that's a marker, of how we get their quality of life and their independence back and their life back, quite honestly.
Hello, and welcome once again to BackTable Urology Podcast, your educational resource for all things urology, and then some. As a reminder, BackTable Urology offers many informative and entertaining episodes which you can find on iTunes, Spotify, and of course, BackTable.com. I'm your host today again, Dr. Suzette Sutherland, and I'm excited to have Dr. Andrew Peterson from Duke as our guest for this special episode entitled The Terrible Urological Five. When is enough enough? And in other words, what we're really getting at is, when is it time really for a cystectomy and or urinary diversion? So good morning, Dr. Peterson. Happy to have you with us here today.
Good morning, Suzette. It's really an honor to be invited to speak about something that's really near and dear to our heart in the whole cancer survivorship world for urology.
First, let me tell you a little bit more about Dr. Peterson. He's a reconstructive urologist who, as he already said, specializes in cancer survivors. He did his medical training at Dartmouth, then his urological training at Madigan Army Medical Center in the Pacific Northwest, the state of Washington. He did a reconstructive fellowship at Duke, returned to Madigan to get his urological chops, doing reconstructive urology there at Madigan. He did that for a number of years and then rose to the ranks of colonel in the military. Leaving the military, he went back to Duke, and there he's been since 2010 for the last 13 years as professor of urology, vice chair of education, the urology residency program director, and the thing, as he said, is near and dear to his heart, he's director of their GU Cancer Survivorship Fellowship. So he specializes in very complicated reconstructive surgeries, and he's here today to share with us the experience-gained wisdom he has, which is turned into very practical advice about managing some of these very difficult patients with devastated bladders and urinary issues. So thanks again, Drew, for being here. We're really excited about this podcast. Okay, so let's get started. I think a good place to start really is first a discussion talking about issues concerning cancer survivorship in this country. So our advanced medical technology, as we know, helps us combat cancer, right? So we have more aggressive therapies and more successful therapies, but, they're not at a cost, and that's what you're dealing with, right? The cost is usually a quality of life issue, but, sometimes these things happen even years later. So tell us a little bit more about that, the statistics and the things that you see.
Right. Yeah, it's really interesting to see the evolution of combined multimodal therapy for different malignancies. If you look at the number of cancer survivors that are alive in the United States in 1975, it was only about 4 million people. And we've seen an exponential rise in that over the past several decades, whereas in 2020, we were looking at about 18 million Americans had survived some form of malignancy. And the estimate now is that by 2040, we're going to see 26 million to 30 million Americans. I mean, that's 3 to 4 times the size of New York City. So the idea is that these people are living longer, they're surviving longer, and so we're seeing really what I'm referring to as a survivor bias. In other words, patients are getting such good therapy and such life-saving therapy with these types of things that they're living longer and they're actually being cured. The problem is that now with patients living much longer, 10 and 20 years, rather than the early on 2 and 5 years survival, we're seeing now side effects from that very complex life-saving therapy down the road, oftentimes about 10 to 20 years down the road, long after the radiation oncologists who have assigned the radiotherapy have, deemed that patient a cure and stopped seeing them in follow-up. Furthermore, as a urologist, if you look at who the survivors are in the United States, many are breast cancer survivors, prostate cancer, we know about that. But if you look at the primary malignancies that are treated or the organs that may be affected from those primary malignancies, over 2/3 of the cancer survivors in the United States have either survived some sort of genitourinary or gynecologic malignancy, or they've survived a malignancy that may have effects on their neighboring organs, such as the bladder. For instance, rectal cancer survivors, we're seeing a lot more of those now, cervical cancer survivors and the like. So in the urology world, 2/3 of these 20 million people are actually going to either be a survivor of our malignancy or actually a survivor of a malignancy that affects one of the organs that we deal with every day. So I think we're going to see more of these people in our practices and follow up with different types of things such as hematuria, pain, dysuria, and incontinence. But really the thing that we're seeing as a tertiary or quaternary referral center are the people with what we're referring to now as this end-stage bladder that I think we're going to be talking much more about in this podcast.
Yeah. So, I see quite a bit of that as well. Women that have pelvic malignancies and then metastatic going to the bladder, affecting ureter, so on and so forth. And they're so thankful for the treatment that helped cure their cancer. But now we have to deal with these problems that they have after the fact to try and get them a good quality of life. So I see exactly what you're seeing. I see mostly in women. Of course, you see men and women.
This is actually an embarrassment of riches, and it's a good problem to have. It shows how good our therapies have gotten, and these are life-saving therapies. So, the message I always like to put out is these are not complications of radiotherapy. These are side effects of life-saving therapy that we don't see for 9, 10, or 15 years down the road. So I think, like I said, we're going to see more of these patients, and we have the ability to take care of these folks and also treat them appropriately and increase their quality of life significantly.
I think what's really important is that the patients are well informed about some of these things. Now that we have more experience over the last several decades with what kinds of things can present at late stages, right? We can counsel the patients a bit more about these are things to watch for. These are things that may be in your future. Things are going great today, but in 10 years maybe. So, make sure we still have tabs on some of these patients. And I think it's only fair to them to understand. Again, I want to make the point, and I like what you just said, that we're not, we're so thankful for the chemotherapeutic agents that we have. Radiation has gotten refined, surgical procedures, all of these things that help us to cure cancer. We just have to acknowledge that nothing is without risk, and there are some downstream issues that happen, and that's what we're trying to help piece those things together. So I like the way you said that, side effects, rather than saying complications and blaming it on the person who cured the cancer, right? So let's get to the meat of what the title of this was. I heard you speak on this before, of course, Drew, and I was just so impressed with this. You talk about the terrible 5 there, the terrible 5 urological things. And if you have 3 of these 5, then that's where you really start to think about, are we really in a position to improve someone's quality of life by continuing to try and save their bladder or do some very creative reconstructive surgery that might then break down or have some other, side effects, right? And so when is enough enough? I want to just outline what these 5 things are quickly, and then just so that the audience can get them in their mind, because this is a podcast. I wish we had a slide and we could have the 5 bullet points up, but then we'll get into each one of them in detail. We're talking about number 1, the devastated outlet, right, with massive incontinence. Number 2, the hostile bladder with chronic pain issues. Number 3, recurrent hematuria. Number 4, fistula in a variety of forms. And number 5, now upper tract consequences of whatever's going on in the pelvis. So those are our big 5 buckets. And so I'd like to just break each one of those down a little bit, and you tell us your experience of what you see and when is it really an ongoing problem. So let's start with the first one, the devastated outlet.
Yeah, let me make a comment about how we came up with these 5 as well. When you review the 5, the devastated outlet, which is the stricture in addition to sometimes incontinence, typically in the man who's been treated with radiation therapy for prostate cancer, we all have that patient in our clinic, and we manage that very appropriately. the person with the hostile bladder or the decreased bladder capacity and the urge and frequency after radiation therapy, even pain, we all have that patient too. If that's their only problem, that's very appropriate to take care of it. Similarly, we all have a patient with recurrent cystitis or radiation cystitis, and we admit him in the hospital, and hopefully it goes away, never comes back. And then most of us will have some sort of fistula experience in our practice, like a rectourethral fistula or an anterior fistula. And then many of us probably won't see the upper tract deterioration down the road, meaning you get hydronephrosis from an end-stage bladder. What I want to make a comment about is managing one or two of these things is very successful oftentimes when we see these. For instance, when faced with the patient with devastated outlet, I think most urologists in the country will manage those men quite appropriately, open up their outlet, then treat their incontinence with an artificial sphincter or a sling down the road. What we've found anecdotally is when you start adding these up, the chances of getting a good, durable cure that helps the quality of life for the patient starts going down drastically. So you've asked me to, again, treating one or two and getting a cure there, that's very possible. When you start adding them up and stacking them, I think that's a harbinger of really the overall damage of that bladder down the road, and it's probably going to be what we call a non-reconstructible or a time for an abandonment procedure, I call it, where we abandon that bladder down the road.
Yeah, I was going to ask to start with the first one and just talk a little bit more about your experience and what kind of therapies that you see, life-saving therapies that are contributing to some of these problems as we go down through each 5.
Right. So the index patient for all of us with what I refer to as the devastated outlet would be a male who is a prostate cancer survivor who had either external beam radiation therapy for adjuvant or neoadjuvant therapy, or maybe brachytherapy or the combination thereof. These are the men who show up 2 or 3 years after their radiation therapy, and they have scar tissue that you have to open up a couple times and hopefully stabilize. But oftentimes they have scar tissue associated with significant incontinence. And so the problem is that now is a devastated outlet. That's one who gets troublesome recurrent stenosis and it lands them in the ER repeatedly, but they've also got massive incontinence. So the treatment for that can be quite tricky. Many of us in reconstruction will open up that outlet, put a man on CIC or stabilize the outlet for a period of time, and then come back later and put an outlet procedure on them for the incontinence. And that can be done safely and it can be done very appropriately, but you have to watch those patients for a while. The trouble with that is that long-term follow-up, oftentimes you start seeing other problems with the bladder down the road, and we'll get into those down the road. The next thing we typically might see would be the hostile bladder, or what I refer to as the angry bladder. These are the index patient would be anybody who had type of radiotherapy for their pelvic malignancy, cervical cancer, rectal cancer, of course, prostate cancer as well. These are the patients that are typically 5 or 6, maybe longer years away from their life-saving radiotherapy, and they show up with urge and frequency, maybe a contracted smaller bladder and urge incontinence and that type of thing. And all of us, I think, will initially start them with behavioral therapy, fluid limitations, this type of stuff, but rarely that works well in the radiated bladder. Then we'll move on to the oral anticholinergics or the beta 3 agonists, or even combine those two. And then we're looking at Botox therapy, and some people will even try implantable stimulator devices, which don't work as well when you have a mechanical problem like this. So these can be difficult to manage in the radiated bladder as well. But we can oftentimes get a very nice result early on with these oral therapies or even injectable therapies such as botulinum toxin. So those first two, the devastated outlet and the hostile bladder, can be managed pretty nicely when they're alone. But when you start adding them up, they start getting harder. The next category would be the recurrent cystitis. This is the radiation cystitis patient. Again, an index patient could be any survivor of malignancy. The classic that we're thinking of are the prostate cancer survivors, mainly because no matter how good you get at targeting radiotherapy, there's always a component of the bladder involved in that radiation exposure. That's your organ at risk area. And if you really learn how the radiation therapists target and dose their radiation therapy, you've learned that there's no way to avoid that almost completely. So there's always a component of that bladder that's exposed to radiation therapy. And that can develop over years into inflammation, end-stage arteritis and the like, loss of your protective layer of the bladder, and then, of course, intermittent bleeding. And that also leads to other problems as well. 1 or 2 bleeds, usually not very troublesome. They can be treated acutely, with your Clodevac and that type of thing. We find hyperbaric therapy works incredibly well for these patients down the road. And again, if it's by itself, go ahead and treat that type of problem and get them through that. If they have that plus some incontinence, you can move on with an incontinence therapy later on. But if you start seeing a third one, you have to start, I think, asking yourself, is it really right for me to treat recurrent cystitis plus the outlet plus the hostile bladder urgency and frequency stuff all together as we move forward?
I would say in my world, seeing mostly women, what we see is a lot of the radiation cystitis with the cervical cancer. So much radiation is being used for cervical cancer these days, and I'm just surprised, in spite of, zoning in on just the cervix with the radiation, how much of the bladder does get affected and how late that can present as well and still be problematic years down the road.
Yeah, and cervical cancer survivors are really a special group because they tend to be younger. They tend to be still active, still in the working age. Many of them are in their 40s or 50s or even younger than that. And the radiation dose, boy, for that life-saving therapy is a much broader field. So you've got many more organs at risk there. And so you're going to see a lot more damage down the road. But having said that, these women are living longer and longer now because of these multimodal therapies that they have, and they're very aggressive with these. And we're going to see patients that show up 10 years out who are NED or don't have any more disease, but now start developing these types of problems that we're talking about today.
Okay, and the fourth?
Yep, the fourth one that many of us won't see in our practice is the fistula. Radiation can cause connections to other organs. The classic would be the rectourethral fistula. Those can be repaired if they're by themselves. And we have a pathway at Duke to do that with a multidisciplinary team. We've got fairly good results with that. It's not 100%, but when you're looking at an 80% success rate, that's pretty good for a radiated fistula, considering that we're determining our cure as reversal of the colostomy and peeing out your penis down the road. The fistula many people don't think about, but gets a lot of talk now, is an anterior fistula. So you can also get fistulas from the bladder or the old prostate fossa to the pubic symphysis. Once you bathe the pubic symphysis in urine, you can infect the bone next to it, and you can end up with pubic bone osteomyelitis. And that, unfortunately, is one of these findings that almost always results, is almost never curable without removing the bladder. But the posterior fistulas, the rectourethral fistulas, can be cured quite frequently with different types of surgeries if you agree with the York-Mason approach or perineal approach, with very, very good outcomes.
So I was just going to ask before we move on to the next one on that, just a little side note, just for practical purposes. So in a radiated field, of course, fixing the fistula, are you augmenting it with anything or using any type of graft material or anything to try and support it since that's radiated tissue?
Right. Our pathway here, we split it into the radiated versus non-radiated rectourethral fistula pathway. The non-radiated people we find can do very, very well with a posterior-based approach, such as a modified York-Mason that we're doing now, without putting a big gracilis muscle in there. The radiated folks, so all get passed over into the perineal approach in our algorithm. So every one of them, regardless of size, does get a gracilis interposition, ornamental interposition based on how we approach it for those. And that's because they're radiated and we want that non-radiated good tissue in there. So, but again, they can be fixed very successfully if the bladder's good capacity, if you don't have a hostile bladder, you don't have recurrent cystitis, which sometimes if you query these people, they've got, more than just one problem when they get to the fistula problem.
Yeah, I would say some of that information is the same for our vesicovaginal fistulas, which is what we see then, right, with cervical cancer patients sometimes. So,
boy, thank you for bringing that up. As you remember, I did a lot of female pelvic medicine as well before I evolved into this field. And boy, fixing a non-radiated surgically induced vesicovaginal fistula, one of the most gratifying things that you can do for a woman. Fixing a radiated vesicovaginal fistula, one of the most gratifying things you can do for about 3 to 6 months. And because you can oftentimes get a repair, but since it's radiated tissue, if you don't do a nice interposition, you're going to probably see recurrence of that. So we see those, I didn't mention that, I was neglected the vesicovaginal or vesicoenteric fistulas that you see in the cervical cancer survivors as well. Very challenging to fix those, but can be fixed if they're by themselves.
So it is just a good overall surgical, good practice principle, right? So interposition when it's radiated tissue.
Especially with the type of dosages that we're seeing in the pelvic malignancies.
Right. Okay, and the fifth category, upper tract consequences.
Yeah, so we've seen several patients that were referred to us with a radiated bladder and a single ureteral stricture that resulted in hydronephrosis, very successful reimplant done at another facility, and then come back with now the contralateral side has stenosis and requires a reimplant. Oftentimes when we evaluate those patients, would be the index patient, the patient with cervical cancer or prostate or rectal cancer who had radiotherapy, showed up with a single ureteral stricture, you reimplanted it, and about 2 years later, you see the other side is strictured now as well. That's a radiation damage to that area organ at risk down there at the trigone, which can cause scar tissue and then obstruction of that ureter. Early on, that can be managed very nicely with a robotic reimplant or an open reimplant, however you'd like to do it. However, oftentimes when we see one side affected, the other side's at risk too. So I always worry about following those patients very carefully and making sure that the contralateral side does not cause you problems later as well. Now, having said that, if you see ureteral stricture in combination with overactive bladder that's urge and frequency from the radiation, plus a couple episodes of radiation cystitis, now you've got three things, and you probably should start asking yourself, is it really appropriate for me to reimplant this ureter, maybe do an augmentation cystoplasty at the same time, then come back later and do an outlet procedure such as an AUS or something like that because they're incontinent. And down the road, what you may find in that situation is that bladder is going to continue to deteriorate and continue to cause you problems and recurrence, and all those surgeries, those beautiful surgeries that we do, may really not help that patient out at all. So where I'm going with this is anecdotally, originally we saw a series of patients referred to our practice for a redo ureteral reimplant or an augment, that was the request, or an outlet procedure. And when you saw them, we would do those, but we'd also add the augment to it. And we found that those surgeries were not working. Those were our hands. So it was something we started asking ourselves. Then when we really looked at this group, we were able to define these 5 categories, these terrible 5. And what we found with our anecdotal evaluation of our first several series of patients was that once you got 3 or more of these, no matter how expert the surgeon was, no matter how perfect the surgeries were, when you've got 3 of these, typically they came back with another problem down the road and another problem and another failure. And what we started asking ourselves, is there a cut point or a tipping point where the bladder no longer is actually salvageable? And so that's where we started talking amongst ourselves about what is the end stage bladder. And I'm becoming more and more convinced as we continue to follow these patients and follow this data that of these 5, if you've got any 3 of these 5 altogether, that's the point that we look a patient in the eye and we say, this is the bladder telling us that the damage to it's too great. It's probably not going to be reconstructible. And my guess is that it's now time to move forward, remove the bladder, and just go forward with a urinary diversion.
Yeah, at the end of the day, even with a cystectomy urinary diversion, the whole point is to try and then improve their quality of life. But really, that's a hard step to take for patients. Certainly, I'm sure nobody goes into situations like this thinking they're going to lose their bladder. But it's a very real conversation that has to be had. How, and also those cystectomy urinary diversion has its own set of issues that can develop right down the line there. So how do you then move through preparing a patient to see that there is, a light at the end of this tunnel through a urinary diversion?
Yeah, when we started having these discussions with patients, hitting them with the idea that the best option may be to abandon the bladder, we learned that these sometimes are 2 to 3 hour clinic appointments. Many patients have driven 5 or 6 hours or gotten on an airplane to see us. Oftentimes they've been told, I'm sending you up there by their referring urologist. I'm sending you up there because they can fix this. But what they don't know is oftentimes the fix is not what they're expecting. And, we teach in the fellowship, and I actually still abide by it. Many psychologists have some critiques about the old Kubler-Ross grief cycle, but we have actually watched patients cycle through this in clinic over a period of minutes. And we've also had several patients that I've known were referred to me and went through it over several years. The denial portion, the classic example of the denial component. I'll just go through the 5 stages of the Kubler-Ross, and you can look it up on your own as well. But, you've got denial, then anger, then bargaining, then depression, and finally acceptance. And the idea is we were taught in medical school you had to go through them stage by stage, but many experts think they can all happen at once. But I'll give you an example of a great one that has gone through stage by stage. The denial phase. We'll sit down with a patient who had radiation therapy 10 or 15 years ago. Their cancer's cured. And we'll say, we think that the radiation you had damaged your bladder to a point now that it's causing these problems, and it's not reconstructible. And our recommendation would be move forward at this point with a cystectomy and urinary diversion. That's your classic patient who had brachy plus a boost 10 years or 15 years ago, and now presents to you with recurrent cystitis, devastated outlet, and decreased capacity. The first thing they'll say is, but my radiation therapy was 10 years ago. It can't be that. And I would say that that's your classic denial. Many patients will then start out in the anger phase, and I think we've all seen this. And that's the classic, well, I should never have gotten that radiation therapy. Everything I have has been caused by that radiation. Typically, our response is much more informative and emotional support at that level. What we'll do is always remind patients with that form of what we call decision regret at that time, that they made the right decision with the information they had at the time. And I always remind people that their cancer is cured, and so they're here now 10 or 15 years later. I think we also can all remember a patient in our clinic in the bargaining phase who has this type of bladder. That's the patient who's already had, they've got urgency and frequency, radiation cystitis, and massive incontinence. They've already been tried on many oral therapies, and they say, well, doc, can we try Botox this time? Well, I read about this thing called the interstim. Can you augment my bladder? You know, that's the bargaining phase. And I had 2 patients so far that took 2 years to get through this process. One patient made me do everything that was possibly available at the time, Botox and AUS. I did not do an augmentation cystoplasty. But by the time we cycled through that, then the acceptance came in. So the next stage after bargaining is typically the depression. Most of these people are, I think, depressed concurrently with this because we know that men and women with severe incontinence or bladder disability, depression's associated with that. We just found that out with the OSCO trial that many of us were involved in, where we looked at pre and post depression and anxiety scores before and after placement of a sphincter or a sling. And then finally, acceptance. And the acceptance phase usually happens in this manner. Dr. Peterson, I came in and started seeing you 3 months ago. We've been talking about this for 3 months. I'm ready. Can you do my surgery tomorrow? Not making that up. Many of them, once they've come to that decision, they're ready to go forward. I'm confident.
Before they change their mind, maybe.
Well,
right.
believe it or not. Yeah, that's a great question. Once we've cycled through these, I have yet to have a patient come back and tell me I changed my mind. I don't want surgery. Typically, it's can you do it tomorrow? And then when we see them the morning of surgery, they're there with their family and everybody's relieved and they're ready to move forward. And I'm going to tell you later on, I think, the outcomes are quite good with cystectomy and urinary diversion in all comers, quite good with both quality of life scores, but also physiologic follow-up scores. And we did some great projects there with the help of some medical students that worked with us in our group and in our fellows.
And then let's talk a little bit, though, a patient says, okay, I'm ready, but now you also have to prepare them for that big surgery that they're going to have that also is associated with some complications. Now, I will say, in all fairness, there are some techniques that have advanced that make these surgeries even safer and having less problems with stricture down the road and things like that. Can you speak to that a bit?
Yeah, I'm glad you bring that up. I think the biggest fear of all urologists, my oncology colleagues here, think I'm crazy because we're doing a radiated cystectomy every week. I shouldn't say this in the podcast, but it's actually not that dangerous and it's not that hard. I'll be very honest. The idea is that these are not cancer surgeries. These are quality of life surgeries. With that knowledge in mind, we've modified our technique of cystectomy where we can safely take the bladder out first by mobilizing it, then bivalving it because we don't have to keep it separate from the abdominal contents. There's no cancer issue. We've already scoped them and made sure. And with the advent of various modalities such as our sealing devices now, such as the ligature and these types of things, you can safely take out a radiated bladder with really minimal blood loss at this point because it's a completely different operation. We do remove it up to the trigone, but I typically leave the prostatic capsule in those patients there because honestly, when you open them up, it's just a bunch of goo at that point anyway. And so you can take that out. So it's not a cancer gold cystoprostatectomy where you have to get clean margins and you have to put the rectum at risk. One of the things we train here also is, above all, don't put the rectum at risk. The worst thing for a patient is to wake up with 2 bags, one for urine and one for stool, and a radiated rectal injury is probably going to be a permanent bag. But having said that, in our cohort of over 150 patients at this time, we have yet to have a rectal injury that's resulted in a permanent colostomy. So it can be done safely. It can be done with very minimal mortality. We have yet to have any deaths in the 30-day range for these patients, and we've done these surgeries on much older folks. And I have to attribute that to the expert anesthesia and our preoperative evaluation that we have here that I'm so proud of. And it also can be done with your average hospital stay. Our average length of stay in these men and women is around 7 days, which is very equivalent to your non-radiated cystoprostatectomy patient. Our readmission rate, I'll be very honest, is around 20%, which if you look at national data is about equivalent to your cystoprostatectomy patients.
What's the main readmission reason?
Yeah, it's typically a metabolic problem. They go home and for some reason after about a week, they'll get dehydrated. And the majority of these admissions are an overnight type deal. Hydrate them back up, get rid of the acidosis that's developed and get them back on their feet. Nutritional sometimes as well. Some of these folks aren't back to eating as well as you think they are when you send them home. Infection is very rare now in our hands, and we're not sending people home on prolonged antibiotics unless they have something like the osteomyelitis patient. But, if you look at those types of early morbidity markers, this is not that devastating operation that I think we were told about 20 years ago, where, it puts everything at risk. You're going to wake up with 2 bags. Don't even think about it. It can be safely done. And with a normal hospital stay, a normal postoperative readmission rate and the like. I think one thing we have to get careful about is admit that these are very large operations and that a readmission and a complication is almost expected. I'll be very honest with you. So assuming we're not going to have anything happen, I think is a little naive. I tell my patients the complication rate is around 100%. But, if you look at Calavian 1 through 5, the majority of them are going to be the very low-level complications that we deal with in clinic. And then the higher ones will be an admission, maybe a fluid collection, this type of thing. I was talking with a good friend of mine who does the same type of work at Vanderbilt, Melissa Kaufman, and I told her my complication rate is 100%. And she shook her head, and I thought I was going to get severely criticized. She said, I don't think you're right. She said, I think it's 200% because when I do these, sometimes they have 2 complications. But realistically, with a good team, we're all trained to take care of these, and we can get these patients through these. The real proof in the pudding after going through that is when you see them back a year or 2 later. And I have a video that I've gotten permission to use that I put in one of my talks now that you haven't seen. Some patient testimonials. Seeing them back a year or 2 years later, there is a common statement all of them make, and sometimes the spouse makes a statement, and it's the quote, I wish I had done this 5 years earlier. So that was what started really cementing it for us when we saw these patients in follow-up, that we're really doing them something that's very beneficial. We're getting them back to their lives. I've got a man who owns a tree service, and he still climbs up in the tree and drops those big branches down on the guys below him. And he's 72, and he's got, a bag now. He couldn't do that before. I've got a patient who just got back from Iceland where he was hiking the glaciers, for a week at a time with a bag. I've got another person that was still scuba diving. He stopped now because he's 80. But, he was doing that with a bag. So we can get these patients back to their lives. I think the classic deal is some of these patients have been in and out of the hospital, multiple blood transfusions, multiple emergency room visits in the middle of the night for a stricture that closed off. Then they've got an upper tract problem and they get a perc tube placed, or they've had a bunch of stents in place, multiple procedures, multiple surgeries, multiple infections as well because of that. We can do a safe operation that takes a day for us to do, a week in the hospital, and with a codified team can be done very safely. And when you see them back a week later or a year later, they can be almost a totally different person. We've got data to show that too. We had some follow-up studies where we looked at metabolic indicators and quality of life scores, and they significantly improve after this operation.
That's wonderful. I remember when I was in training, so it was a number of years ago now, of course, but we called this operation the big, bad, ugly, heinous surgery, right? But the way you've described it now and what we've also experienced, as you said, there are ways to do it more safely, and it's maybe laborious, but certainly safer for the patient and provides a wonderful opportunity for a return to a quality of life, which is great. Yeah, so let's touch on a little bit if you have any organizations associated with Duke or with your department that provides some support services for these patients. Do you feel like a support network of other patients who've gone through this is helpful for them for the emotional thing, especially in the first maybe year or so?
Yeah, the year of recovery, you mean. Yeah, there are plenty of ostomy support groups. I just don't have their names offhand. I do caution some of our patients, be careful what you find on the internet. There are sites that have agendas against having bags. I will tell you that we offer continent and non-continent diversions, and the majority of our patients actually choose a non-continent diversion, a urostomy. Quality of life scores for those are equivalent for continent versus non-continent once you get 2 years out from surgery, and the body image scores are similar as well. So it doesn't matter what you get. Patients are equally seemingly as happy with those. That's borne out in various studies. So I caution patients to be careful of some of the internet sites where they might run across a place where somebody's really got agendas against bags. There's an Ostomy Association. The Crohn's Association has great information as well. And then, again, I couldn't do this work without the incredible support from our interstomal therapy team at Duke, where it's a whole crew of nursing staff that this is all they do. It's their full-time job. And I'll tell you, they can get a bag on anybody. So I'm rather lucky with that. But with the products we have nowadays, you can get a bag on anybody, basically.
Well, that was wonderful. I don't know if there were other issues that you wanted to address for today pertaining to this, other points you wanted to make?
No, I think it's important to remind people that you and I, Suzette, we train same time frame, and I was taught that an exempt for a survivor or an exempt of an operation for anything other than cancer was really a bad idea. And I was taught, don't do those. People don't live through them. You're going to end up with 2 bags. It's going to be miserable, and the patient's never going to survive. But we've got long-term follow-up on these patients now where we've taken their bladders out. Sometimes we've given them 2 bags. We've done a full exempt. And like I said, when you look at physiologic indicators of health, such as albumin, how their creatinine changes, how their hematocrit glucose and their acid-base status changes, they do just as well as de novo patients. When you look at long-term patient-reported outcomes, such as an SF-12, which has a psychiatric or psychologic component and a physical functioning component, those scores go to normalized after these types of surgeries for these patients, and they're terrible pre-op. And then if you look at depression scores like a PHQ-9 or any other things like EQ-5D that have anxiety scores on them, the anxiety scores and depression scores and anger scores are off the roof. And then you do these surgeries, and at a year follow-up, they're normalized. So we can really get these folks back to their lives. Another just very anecdotal thing that I think is appropriate to mention as well, and this is what I tell the fellows and residents, this is why it's important to see clinic. It's important to see clinic because you see these patients 2 years after you do this massive operation, and you realize that they're going to do okay. And it makes it easier to handle the problems that come in and to talk to these patients because you know what they're going to look like in 2 years. I can't tell you how many times we've had patients come in with their entire extended family when I meet them because everybody thinks that mom or dad is going to die and this is the end of it. And then when they come in for their 1 year follow-up, they're by themselves. And you say, where is everybody? Well, they're out shopping or taking care of themselves. So I think that's a marker, of how we get their quality of life and their independence back and their life back, quite honestly.
Yeah, I think all too oftentimes the urologists themselves, right? When they can't fix different things in these categories and they have to resort to a cystectomy and diversion, they feel, it's a reflection on them as a failure as a urologist. And I think the important part of this podcast is really that that's not the case, right? Repeat, interventions, trying to save something that's just a lost cause, you're just harming overall the patient more and just sometimes doing the cystectomy and urinary diversion is the best thing you can do for the patient.
Boy, thank you for bringing that up. That was perfectly phrased. I think that all of us as surgeons and clinicians, we're all trained that we want our surgeries to be successful. So when we have a patient where we do an outlet procedure on and it doesn't work, and then they come back and we do an augment and it doesn't work, and then they come back and they've got recurrent bleeding. That is not on the healthcare that's provided. That's on the disease process. And those dye were cast 10 years prior, and this is just an evolution of that process. And we did the same thing. I was beating myself up as to why I had to redo this or redo that, or why now I have a new problem. And it's when we sat down and we looked at it, and we learned that as you add these up, that's just a marker of how damaged that bladder is, and it's time to remove it. So yeah, we see a lot of patients, I think, that are in a vicious circle, and probably because people want to really help them. But sometimes the help is to say, no more. Let's talk about abandoning the bladder and getting you something to replace it and get your life back to you.
Great final words. Awesome. Well, thank you so much, Dr. Drew Peterson from Duke University. I think this is very practical and valuable information. Thanks so much for being on the show today.
Thank you so much for having me.
Again, I'm Suzette Sutherland, your host today, signing off until next time.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.